Good morning, sir.
Good morning. How are you, Dr. Manju?
I'm good, sir. Sir,
Yeah.
I'm very happy to see you. I wish you were here on physically in NMR.
Yes, yeah.
So, but sir, we are very grateful to you for consenting and agreeing to give this lecture. I'm very happy to have you here
Yeah.
in this lecture.
Yeah.
And so I think people have joined. Sachin, is the time correct? It's 11 o'clock.
Yes, we can start now.
Not only in this lecture, Dr. Manjura here, I would like to be associated on a continuous basis with the NIMR. I always have an affection for NIMR right from beginning. So in any of your projects or any of your advisory capacity and all that, I'll be happy to get associated.
Thank you, sir, so much. Thank you so much for this affection and continuous support. I intend to reach out to you separately. And maybe after this lecture, if you're not too tired, I'll give you a call and have a plan in mind.
Yes.
So we will talk about it, sir. I have something in my mind.
Sure.
Yes, sir. And so, Sachin, if everybody has joined, we will open it quickly so that we can have sir's lecture very properly. Good morning to everyone, and today is a distinguished lecture series, one of the lectures on malaria elimination, and we have the privilege to have Dr. Ravi Kumar with us, and he has been associated with the national program for a very long time. He has a rich experience and rich expertise in the area of not only malaria but in general vector-borne infections, and being a medical background, he understands the disease from all aspects of epidemiology and disease and management and treatment. So that gives a holistic and well-rounded opinion and views on the disease. And he has also been at the helm of affairs for writing the national strategic plan. So he knows, he's totally up to date, and he knows where the program, the direction the national program will take in context of malaria elimination, which is of utmost importance to us as well, because we need to align our research work, our priorities, the public health operational research priorities towards elimination. And of course, being a research body, we can continue doing our basic research and our other research work with passion. And I was very happy to hear him during our annual day as well, where he gave his explicit comments and viewpoint on how do we need to move forward, aligning our priorities with the program. Having said that, I will not deprive you or myself from his lecture. Sir, I heartily welcome you to this online lecture, and we wish you can be here in the coming months, and we plan to work together, and so having your more and more presence with us. Thank you, sir, for consenting this. Over to you.
Okay, thank you,
Sachin,
Dr.
want to
Rahi.
open?
Yeah, thank you, Dr. Rahi and Dr. Ravi Kumar for joining us. As Madam mentioned, we had him, here as one of the panelists in the panel discussion when we were celebrating NMR annual day. So we are really grateful to Dr. Ravi Kumar that he has, agreed for this lecture, and this is our distinguished lecture series, and this is the 13th lecture of the series. Before that, we heard Dr. Raman Velyadul from WHO, and before Dr. Ravi Kumar start his presentation, I would like to introduce him officially. So, Dr. Ravi Kumar is at present as an independent consultant and public health advisor in Bengaluru, India. He did his MBBS from Bangalore University and MPhil in Hospital and Health System Management from BITS Pilani. He has worked in Chennai Health Service of Ministry of Health and Family Welfare for 39 years in various capacities and retired as a Senior Regional Director, NCVBDC, Karnataka, India. He has worked as a Chief Medical Officer in the Department of Epidemiology at National Institute of Communicable Disease, which we know now as NCDC, Delhi, for about 2 years. He has been a trainer in Integrated Disease Control Project and conducted numerous training programs for state and district level officers. Dr. Kumar has also worked in WHO Country Office India as NPO for malaria for about 2.5 years, during which he was responsible for refinement of the country action plan and implementation of rollback malaria. He has assisted Government of India in the monitoring of implementation of Joint Action Plan Bangladesh, Bhutan, India and with Nepal for control of malaria and Kala-Azar in border areas. He has extensive experience in monitoring and evaluation of different programs like NCVBDC, Integrated Disease Surveillance Program, etc. He has played a key role in the development of country-level proposals like National Strategic Plan for Malaria Elimination and was involved in the formulation of very first GFA-TM proposal for India and in developing India's proposal for World Bank-funded Enhanced Malaria Control Program. He has supported the development of the state framework for malaria elimination for Karnataka state and has been chairman of the subcommittees on communicable disease in Vision Group, which he has developed the health plan for Karnataka. In 2020, he participated as a core group member for Malaria Programme review and in joint monitoring mission for lymphatic filariasis in India. So, with this, his brief introduction, I invite Dr. Ravi Kumar to start his presentation. Over to you, sir.
Yeah, thank you, Dr. Manjurahi and Dr. Sachin, for a very generous introduction. That's very nice of you. As I told, it's always my privilege to get associated with any activities of NIMR, because NIMR is one dedicated agency which is helping the program in all the research activities and more of a operations research also on a day-to-day activities. You're guiding the program, and your research in various states also have complemented the efforts of different state governments. So with that in mind, what I like to do is to talk to you, discuss with you about the general surveillance activities of malaria. Number two, what refinements are required in the field of surveillance in the context of elimination. Number three, since a lot of the participants today are from research background, I would like to spend last few minutes of my lecture on identifying some priority areas for research in terms of relevance, in terms of its application in the surveillance activities of malaria, where you can be an active partner, not just a bystander or not just a long-term research. Instead of that, how you can help the program in achieving the goal for elimination. So with that, I have prepared a small PPT. So let me run through the PPT and discuss with you. Now, can you see the slide, please? Yeah.
Yes, sir, we can see the slide.
Okay.
Yes,
now,
sir.
what I would like to do is to cover about the general malaria surveillance process in India, how it is being run. What are the different types of malaria surveillance? How do we classify the cases and foci? India being a vast country in different settings, what surveillance aims to achieve? How do we collect some primary data in terms of moving towards elimination by lot quality assurance sampling surveys? And lastly, how do we also incorporate the component of monitoring and evaluation in the surveillance activities? What do we mean by surveillance? What do we mean by surveillance in the malaria program? Generally, we talk of surveillance being an ongoing systematic collection, analysis, and interpretation of malaria-specific data. Malaria is one of the most organized national programs as far as the flow of data is considered. We used to have a number of reporting formats, which we have now merged into only 4, which helps the program in day-to-day monitoring of the program, in day-to-day planning and implementation and evaluation. It's a very well documented program. So by surveillance, in very simple terms, we search for cases, we treat them, and we interrupt the transmission also. So how do we conduct the surveillance of malaria? Surveillance, as I told you, is case finding and treatment. So how do we do that? So it can be carried out at different levels of healthcare system. India is a vast country with different states and different health facilities. So how do we do it? It can be done in 2 ways, and it's being done in 2 ways in the country. One is the health facility based, whether it is sub-center, primary health center, community health center, district hospitals, private hospitals, medical college hospitals, or any other institutions, etc. Number 2, we don't limit ourselves to that. We also go to the community. So surveillance is also carried out at the community level. We also use different detection systems. One is the case-based, based on individual case investigation and response. We do it in 2 ways, active and passive ways. We also use different sampling strategies. By active and passive, we cover the entire gamut of fever cases in the community. We also do sentinel sites, surveillance for severe and complicated forms of malaria. We also organize surveys to collect the primary data. Our surveillance is also intended to detect and respond to epidemics in a timely way. As the number of cases in the country are coming down, it is significantly coming down. In fact, we are steadily moving towards elimination of malaria. So with large tracts of the country being bereft of malaria, So is there a possibility of malaria coming to that area? Is there a possibility of outbreak occurring in that area? Can an epidemic occur with a larger area and larger number of cases? So we have to be ready for detection and responding. With large areas also being bereft of malaria, what is the possibility of establishment of transmission in that area? When cases are introduced to that area, how do we prevent that? How do we prevent the re-establishment of transmission? So these are all the overall objectives of the surveillance activity. Let us come to the specific objectives of malaria surveillance on a day-to-day basis. What do we do? Our primary objective is the patient care. Person who has got fever, we have to detect whether it's malaria or not. So we ensure early diagnosis and complete treatment. Early diagnosis aimed at preventing any severity or complication of malaria, and complete treatment so that all the parasite stages in the body are completely eliminated, so that number one, there is a clinical cure. Number two, there is no relapse. Number three, there is no transmission also. So the next objective, apart from the patient care, is also to see that we interrupt the transmission of malaria from him to his other family members, to his neighbors, or to the village, or in urban area to different wards, etc. So by killing the gametophytes, we also interrupt the transmission of malaria from one person to another during our surveillance activity. The third objective is also that we identify the target areas and population groups, because as I told you, there are different, India is a diverse country, there are different population groups which are affected by malaria. So what intervention can be done in different areas? So surveillance would tell you what specific intervention measures are required in different areas. Number four, after having put all those intervention measures in mind, can we say whether they're acting or not, whether they're effective or not, whether they're efficient or not, whether they're cost effective or not? We study all that through our surveillance activity. So we also assess the impact of these intervention measures in different areas. So, and then lastly, to find out whether these interventions require any adjustment or different combinations of interventions are required, which is required on a more stronger basis in a wider area with stronger emphasis on particular aspects, or do we need to reduce any particular intervention? And then do we also require more resources? So the surveillance also would tell you the resources which are required for different interventions. So overall, it helps in planning and implementation of the overall malaria control strategy. Now let us go into detail. Let us talk about the different types of surveillance that is happening in the country today. The most effective form of surveillance which is being carried in the country is passive surveillance. We should be proud of this fact that most health facilities in the country now, from the lowest subcenter level to the highest level, have the facility of detecting malaria amongst those fever cases. So whoever fever case comes to this institution, same day, same hour, in fact, we can detect the malaria by either by conducting a rapid diagnostic test or by doing a blood smear examination. So we have got laboratories, we have got laboratory technicians. When a patient with fever or even another suggestive symptom, he comes to the doctor immediately advises the blood smear, sends him to the laboratory. Either it may do an RDT also. So more or less, more often we rely on the blood smear examination. The point in passive surveillance is the speed of diagnosis, the efficiency of diagnosis, and also the possibility of detecting more infections. Passive surveillance is also a very fine filter of detecting more positive cases, because it's only the genuine patients who come to the hospital. So the possibility of detecting positives from them is much greater compared to any other form of surveillance. The important component of passive surveillance is also that we can start the treatment same day. We can initiate the treatment. We can make the patient swallow the tablet in front of us, and then we can give him the tablet and convey the information to the concerned ASHA and the health worker to ensure the full compliance of the treatment. Passive surveillance is the best form of surveillance. It has to be done. But is it just enough? No, definitely not. Because we have to go to the field also. No, why do we do that? Why do we require for community surveillance, active surveillance? Not everybody comes to us. The recent National Family Health Survey 5, which was done across the country, showed that only about 60% of people approach the government sector for inpatients, and only about 40% of patients prefer government hospital for admissions. So is there a possibility of getting all of them? Yes. With especially the elimination in mind, we should be reaching to every fever case in the community and to find out whether it is malaria or not. So right from many decades, India is also proud of putting an excellent active surveillance in the field. Today, every household of every village, in most urban areas, every ward, we have a mechanism to reach them. Our multipurpose worker male and the auxiliary nurse midwife ANM, they visit all villages either on a weekly basis or at least on a fortnightly basis. ANM definitely visits the village at least on a weekly basis. Multipurpose worker male is also visiting every household fortnightly. They look for fever cases. So they current search for the current fever cases in the last 15 days. Anybody has come to that area from an endemic area for malaria. Anybody from this village or this ward has gone to an endemic area. What is the severity? When did the fever start? So they get information regarding all that, fill up a form. They also take a blood smear or conduct an RTT. So with one of these two tests, we can be done. If RTT at the same day, the malaria can be confirmed, or the blood smear, if it is done, it is brought to the primary health center. And that subsequently it is examined and the treatment is started. So at the village level, we also have ASHA. Now, I told you that the ANMs visit weekly and the multipurpose worker visits fortnightly. So what about those fever cases in this interval? So we have in the country under NRHM, we have given the ASHA to all these villages. Even earlier also we had volunteers in the program. We had earlier these drug distribution centers and later the fever treatment depots. Now we rely only on the fever treatment depots. They are also been trained. They are also involved and they are doing the work effectively in giving this early diagnosis and treatment by screening those fever cases also by blood smear and RTT who approach them. Apart from that, we also have the community health officers now. The community health officers at the health and wellness centers, which have been numerous in every state, we give this facility of passive surveillance by taking a blood smear and RTT. We don't even stop at that. We also do a contact survey. Let's say positive cases detected in a particular area. We also take blood smears from all the contacts, whether they have fever or not. Objective is to assess any possible spread of infection among the contacts also. We also have other different types of surveillance. Rapid fever surveillance during a fever outbreak in a given area on a daily basis. Our multipurpose worker and ANM as a member of the rapid response team, they conduct the fever survey of the affected population on a daily basis till the outbreak is contained. And we continue this survey for about 20 days, which is twice the incubation period of malaria, till the last fever case is seen, till the last malaria positive case is seen. We continue this rapid fever surveillance in that area. Recently, Orissa and Chhattisgarh and different other states of the country, they have also done this mass screening and treatment. We call it Daman in Orissa. Chhattisgarh, different names have been given. So we, in an endemic area, in a tribal area, we also do mass screening and treatment. They have shown with their work that it is possible to cover an entire area. We screen the entire population. We take a blood smear from the entire population. I do an RTT for a fever case. So irrespective of the presence of fever, we have screened them. Thereby, we have been able to really find out the prevalence of malaria at that point of time. How many people have been examined, how many people we have covered, how many people we have taken the blood smear or conducted the RTT, and what is the presence of malaria in the entire population. How many among the symptomatics and how many among the asymptomatics also. So with this mass screening and treatment, we have been able to detect so many asymptomatic cases. And the fact that the treatment has been given on the same day in the field, we have been able to interrupt the transmission also. You can observe from the data of Orissa and Chhattisgarh that significant reduction of malaria has been achieved. But it doesn't mean that we do the mass screening and treatment everywhere. There are very clear indications in a remote area, in an inaccessible area, in a tribal area, before the pre-monsoon period, in consultation with the Directorate of NVBDC or the NCVBDC as it is known now, this action has to be taken. It cannot be applied on a large scale everywhere. We also do a sentinel surveillance. 2% of plasmodium falciparum infections, it is they might go for complications, for severity and other forms of complicated forms of malaria. So we also have sentinel surveillance. Community health centers where they're likely to go, district hospitals where they're more likely to go, or medical college hospitals where they definitely go for their treatment. We have identified them to find out what is the proportion of fever cases in the outpatient, how many of them are malaria, how many fever cases are admitted in a particular point of time in these hospitals, how many of them are malaria, are there any severe and complicated forms of malaria which have been admitted in the hospital, what is the treatment that is given, what is the outcome of that particular case, what is the follow-up, and more often than not, what is the efficacy of treatment also. So we have been able to do all this in the sentinel surveillance activity. For the surveillance activity, we also have given a very clear definition, because we have to be very clear. We collect information in different settings with a particular and a very specific definition. So we have given the definition of suspected malaria case, a case of fever within in an endemic area during transmission season, or who has recently visited an endemic area and come to your area, and who does not have any other obvious causes of fever. He should not be having cough or other signs of respiratory infection, running nose, pelvic inflammation signs in women, skin rashes, burning micturition, skin infections, painful swelling of joints, ear discharge, dry ear. So we rule out the other common causes of fever. Then that particular case, we have given the definition as suspected malaria. Now, why do we do that? Earlier in the program, we used to give presumptive treatment. For all those fever cases, when you take a blood smear, we used to give 4 tablets of chloroquine for an adult, and for age-wise, a lesser dosage. Now we have stopped that, because that would increase the possibility of drug resistance in an area. With improvements in surveillance activity, which is no longer required, we can reach a fever case, we can initiate treatment within a very short point of time. But at the same time, a medical officer sitting in the OPD or a health worker, when he goes for active surveillance, if he sees a particular fever case which has come from an endemic area, without even waiting for the blood smear examination, because even blood smear examination might take 24 hours, 48 hours, or 72 hours for examination. If audit is available, fine, but otherwise it would take some time. So without waiting for the confirmation, he straight away starts the treatment, but giving the full dose of chloroquine. We give 4-4-2, assuming that it would respond, only except for some cases of Plasmodium falciparum, which might not respond. Most cases are Vivax in majority of the country, so they would respond. So then at the earliest point of time, we would examine the blood smear and give the appropriate treatment. We are also refining the surveillance activity. We are also giving a very particular format for case investigation. We are also identifying the focus, because in elimination context, we should be able to pick up the earliest possibility of an outbreak. So we have defined malaria focus in a given area. What is malaria focus? It is a well-defined, circumscribed area in either it's a currently malarious area or a former malarious area that contains all those factors which would enable transmission. In fact, this would apply to most parts of the country except Jammu and Kashmir and those highly areas of Uttarakhand, etc. All other areas, there is always a potential for malaria transmission. So any malaria focus would be in most parts of the country if the number of cases occur. So there are 3 kinds of foci also we have defined now. An active focus where there is an indigenous case as of now, and we are doing the investigation and we are putting the intervention measures now. It's an active focus. We also have a residual non-active. We have treated those cases. In the recent years, there is no indigenous cases in that area. Almost up to 1 to 3 years, there have been no case of indigenous transmission of malaria in that area. That we call it as residual non-active. In the elimination context, about 90 to 95% of the country would come into this residual non-active, or an area where we have completely cleared the focus at all, and there is a very less possibility of cases occurring in that area. That means we no longer it is considered as a residual this area for the transmission of malaria. There are many, about 10 to 20% of the country, we can say they have been cleared. Now, why this focus investigation? Why defining a focus? How do we classify the focus in that area? This is for specific intervention measures, which we'll be coming to a bit shortly. Now, what refinements are required in the context of elimination for surveillance activities? I can think of 3. One is the accelerated efforts. Now we have to conduct surveillance in emission mode. Business as usual would not help us. As we move towards elimination, greater efforts are required with the reach and coverage, etc. So we have to monitor the work of the ANMs and multipurpose workers, medical officers, etc., to see that the active surveillance and passive surveillance, they are done in terms of quantity, in terms of quality also. So everywhere, all over the country, accelerated efforts are required. Complete coverage, not a single household should be left, not a single village, not a single ward in an urban area. Under the National Strategic Plan for Malaria, we have written a complete note on the urban areas. We know that urban areas are rather weak in surveillance activities. So complete coverage in the rural and urban area, not leaving a single household also. Number 3, as we move towards elimination, quality becomes very important. The quality of the surveillance becomes greatly important. So we have defined many parameters which would help us in assessing the quality of surveillance in a given area. It will also move towards improvement of quality in that area. So with that in background, we have given some specific indicators. The surveillance, the monitoring and evaluation becomes a very important component. So we have given in the entire this national strategic plan and earlier also in the national framework for malaria elimination, we have defined specific parameters to measure the quantity and quality of surveillance activity. We measure through the input indicators, processes. We also measure the output indicators. We also measure the outcome indicators. So 3 types of indicators. One is the process indicator, the output indicator, and the outcome indicators of the program. Indicators also would reflect in various program areas of intervention. What are they? Now, how is the disease surveillance and case detection going on in an area? So we have defined indicators for that. There are specific indicators for the integrated vector management. And lastly, because the state governments are involved, because different partners are involved, we also have indicators which measure the program management also in terms of the resources given, staff given, etc. All of you know there are some very basic indicators. I will not go into all these details of the indicators. Just I would like to mention about the most important 3 or 4, which is the monthly blood smear examination rate, which shows the processes which are going on in an area, which are the outputs which are coming from that particular area. Mass blood examination rate, number of blood smears examined or RDTs done in the surveillance population into 100. What proportion or what percentage of population that is being screened in a given area on a monthly basis or an annual basis. When it is done monthly, we call it as MBR. When it is done annually, we call it ABR. This would show what is the quantum of surveillance. We know roughly in a given area, 1% of the population would get fever in 1 month period. So if you're able to show that at least the 1% of the population, the blood smears examinations are being drawn or RDTs are conducted, yes, more or less okay. We are able to cover that population. Okay, and in the passive surveillance, about 15% of the outpatients are expected to have fever. So if you take the blood smear from 15% of cases, that could show there is an adequate surveillance which is going on. Okay, after having conducted the requisite amount of surveillance activity, how do we measure the burden of malaria in a given area? How do you know how many cases are occurring? So denominator becomes very important point for us. So in a given population, on an annual basis, number of confirmed cases of malaria. So this would tell you which area is more problematic. Because instead of relying on the total numbers, absolute numbers, when you use the denominator as the total population, we can compare between different areas. We can also compare to the previous period, previous year, or previous decade, what has happened. So we generally measure this burden of malaria in terms of by defining this annual parasite incidence. We also have the annual falciparum index, which is the number of falciparum cases. Because I told you that 2% of falciparum cases they are likely to go for complications. So the annual falciparum index of a given area, or even the PF proportion, that also would become greatly important. Now, but there are different areas of different efficiency. ABR can be less in a given area, ABR can be more in a given area. Only when the ABR crosses 10% of that area, we are certain about the actual burden of malaria in that area. But there are certain areas of Northeast, Orissa, Chhattisgarh, Madhya Pradesh, etc., where the desired quantum of ABR is not being achieved. Okay, what do we do in that case? So there is another indicator called as a test positivity rate. Whatever is the number of blood smears, what is the proportion of blood smears which are positive amongst them? What is the proportion of which are RDTs which are positive? That would tell you what is the likely transmission level in that area. Okay, so that's a very important indicator. We also use the test falciparum rate when we talk about the falciparum cases in place of the total positives. A very important component is a PF proportion. How many medical officers are to be trained? What specific inputs are to be given? What transport facilities are required? What referral practices are required? What drugs have to be supplied in that area? All that would be determined by one is the falciparum rate and then also the falciparum percentage. There are certain areas of Northeast where the PF proportion is about 95%. If you come to south of the India, in Karnataka, it's only about 10 to 15%. In Kerala and different Andhra Pradesh and different areas, it can be 10 to 15%. So depending on the PF proportion in that area, what is the propensity of that area to go for complications, mortality to occur, chances of mortality, all that can be measured by the PF proportion. When we talk of the elimination context, quality becomes an important parameter, very important component. So how do we ensure quality in the elimination context? By doing a desegregated analysis. Today, every subcenter, every health and wellness center, every primary health center, we are able to monitor with this excellent recording and reporting mechanism of NVBDCP. We also have HIP. I will talk about that a bit later. So we are conducting desegregated analysis where the primary health center medical officer would know what is the quantum of surveillance occurring in my area and what is the quality. After having achieved the ABR, can quality still be an issue? Yes, there is a possibility of it. So we have enabled the medical officer to measure the range or the average time lag between collection and examination of blood smears. I was talking about the early diagnosis. So by going through this M3 register at the laboratory, medical officer can find out what is the range and what is the average time lag between collection and examination, so that if there is a possibility of positivity occurring in that area, we are ready and we are able to initiate treatment at the earliest possible time. What is the range and average time lag between diagnosis and treatment? After having diagnosed that case, can a phone call be made and can a WhatsApp message be sent, or can somebody be sent to that area to start the treatment? And how do we tell the ASHA to ensure compliance with that area? Now, are we able to initiate treatment for all the positive cases on the same day? Yes, we are able to measure that. With an excellent recording and reporting mechanism of NVBDCP, it is possible. We are also ensuring in different areas therapeutic efficacy. I know that NIMR has done tremendous work in this field of therapeutic efficacy. Today, we want to decentralize the entire process of this therapeutic efficacy by enabling the medical officers, by enabling even the active surveillance to find out even a remote possibility of drug resistance occurring in that area. So what we do is for all positive cases, earlier we used to do only for PF cases, now for all positive cases, after starting the radical treatment, between the 3rd and the 7th day, we take a follow-up blood smear, apart from following the patient clinically to find out whether the patient has responded properly to the treatment or not. So the proportion of positive cases for which the follow-up blood smear has been taken becomes an important indicator to find out whether this therapeutic efficacy is functioning in that given area. Apart from that, we have got a number of other indicators. We are concerned not only with the efficacy of our treatment, we are also concerned about the possibility of adverse events. So whenever we when we take the follow-up blood smear, we also find out whether clinically he is okay, or if there are any adverse events of any particular drug. That also we have put in place. Today, we can very proudly say to the entire world that we have got real-time case-based surveillance, which is possible in the National Vector-Borne Disease Control Program through the use of the IDSP. Under IDSP, earlier we used to talk of numbers. Now in IHIP, we talk of case-based collection of information. Today, we were only talking about number of fever cases, number of blood smears, and number of positive cases. Today, we can generate on a real-time basis a line list of all the fever cases for a subcenter or a primary health center. So we have got the general IHIP functioning in almost all the states of the country. It is being expanded in the years to come. This will be the major platform. This will be the major portal for collecting information for not only malaria, and I'm told that NIMR is also exploring the possibility of having an integrated surveillance for all the different vector-borne diseases. That will also pave the way for improvement in this integration, this process. Now, what we have done is the IHIP, WHO has supported NCVBDC to develop an integrated platform for malaria itself, which is a subcomponent of this IHIP.